Once again, good afternoon and greetings. My name is Robert Boussard, and I am pleased that you are joining the division in the Medicaid Eligibility Training Part 2. Today we will cover a brief history of Medicaid eligibility at the division, show you how people on Medicaid will be shown in the CDS system, and take time for a few quick questions, then go into the CDS test site for a demonstration. Once again, if you do have questions during our presentation, please use the chat function on the WebEx. Without further ado, Heather Wood.
Good afternoon, everybody, and thank you for joining our training today. As Bob said, this is our Part 2. The first one that we gave on July 11th was kind of a high-level overview, and today we'll give a bit more direction as well as a demonstration. That being said, as Bob also mentioned, we will have time next Thursday from 10:30 to 11:30 a.m. Central Daylight Time, in which following the actual go live of this feature within the CDS, we'll have a little bit more, as will you, idea about what questions and answers we need to really be able to get into, and any sort of problem resolution, and being able to come up with any additional features for this process to be supported. And so we'll be working following Monday. We'll talk about that a little bit more, but also please just make sure to, as Bob said, watch for that invite that will be following in the next day. So as we begin, just kind of some background information that had previously been covered in Part 1. So a couple of points of background. We had previously contracted here at the Division of Behavioral Health with Magellan Behavioral Health, and they actually did a few different functions for us. They helped us with our collection of data, and so folks would enter into the Magellan system, as well as they would work through our pre-authorization. When we had the contract with Magellan, they simultaneously had a contract with Medicaid. This dual contract with the Department of Health and Human Services allowed for them to, behind the scenes, be able to understand that Medicaid eligibility and to be able to help appropriately access and push folks to the appropriate side if there were any issues. Well, when we went into our new CDS contract, obviously that was no longer a feature, and Medicaid also moved on to their Heritage Health plans. So as a result, we have been looking to be able to identify some type of solution to be able to better understand and to be able to help equip providers and regions and the division be assured that the appropriate payer source between Medicaid and the Division of Behavioral Funds through the regions are being utilized for services. So a couple of reminders. August 14th is when the Medicaid eligibility feed to the centralized data system will become effective. And so between August 14th and September 3rd, so that first week in September when you all will begin doing your August billings, you'll need to get in and check your tags. I think that with the onset of the electronic billing system, many folks got in prior to actually getting there and did a lot of pre-work or maybe a little pre-work, but that really helped to be able to have a smooth transition once the electronic billing system went in. Some folks who may not have had an opportunity to get in prior to that first week in August for those July billings likely found themselves with some trouble. So thinking about some of those issues, we want to be able to troubleshoot before that week of billing to alleviate any sort of last-minute needs or panic on your side. So the implementation of this being on the 14th was very intentional. We wanted to help folks get through your July billings and also give time to really get in to be able to anticipate and understand any types of problems or issues. So again, between now and that first week of September, you're going to want to get in, you're going to want to be ensuring the eligibility is checked on your part and that any sort of necessary steps within the centralized data system or for authorizations through the Heritage Health plans is being done. So August 17th, next Thursday, we're going to have a Q&A. Inevitably, there will be stuff that we can't anticipate until the actual feed is live. And that being said, everything has been done sort of theoretically and based upon the information that is known. That being said, we know that we don't know what we don't know. So we want to make sure we've got a plan in place and we've got ample opportunity to work through situations as they come up with you all so that that way billings in September can go very smoothly. So when we think about who is this going to impact, what are the locations and agencies who can expect to see this? So we're looking at the Medicaid-approved agency locations. Medicaid and their provider network is set up by location. Similar, we have set up the CDS in that same fashion with the expectation that each distinct location providing services now has their own individual item in the CDS. So you might only have permissions for one location, or if you are within an agency or organization with multiple locations, you might have actual responsibilities and access to multiple locations. That being said, again, this feed comes back to that by location and only for those locations that are within that Medicaid-approved agency or provider network. Also, when we're thinking about what services we're talking about, we're not talking about the services that Medicaid doesn't fund. We're talking about those services that are shared and consistent, offered by both Division of Behavioral Health and region funding, as well as Medicaid funding. So when someone is Medicaid eligible, the expectation is Medicaid would be used when they are not Medicaid eligible, but they are eligible under the financial eligibility criteria for regions and division funding, that we would be the appropriate payer source. And again, this isn't new in terms of what's been being done, but we're looking to be able to, for these services, be able to put that net back in place as had been available when Magellan was our contractor and the contractor for Medicaid and long-term care. So we have different services authorized and registered, and you'll see the list of those. I'm not going to read through them all, but I will mention that this PowerPoint as well as this training recording will go into the system documentation, so will be available to you there. This list is also available in the past training, but I do want to mention we had neglected to add in specifically dual disorder outpatient for mental health and SUD, so you'll see that has now been added under the registered services. And when we're looking at these naming conventions, these are how VBH specifically names these services. There might be slight variations in the Medicaid, but I think for the most part, folks understand and know what these services are. If you have any questions, you can certainly ask your provider agency super user or your region user, super user, or send those questions to the contacts that will be at the very end of the PowerPoint. So why are we doing this? Really, it's to be able to permit a more complete and accurate identification of the Medicaid eligibility and being able to ensure the appropriate funding sources used. We want to make sure that this is being used in conjunction with those other Medicaid resources, such as C1, the NIMS line, to be able to help inform you as providers on the current consumer eligibility status. But again, this is not anything new. The current expectation, as has been the expectation, is that on a regular basis, as there might be Medicaid eligibility changes that take place, that you are following the steps that would concur with those necessary changes in eligibility. For instance, if you have someone who became Medicaid eligible for an authorized service, you would need to ensure to go through the authorization process that Heritage Health Plan had in place. So providers are expected to track that member eligibility status and to be able to secure those authorizations through that appropriate funding source. The CDS has a semi-automatic authorization process, which for folks who go through that, you're familiar with that, and we had that implemented when we went live last May 2016. So again, this is an ongoing activity and process. It's not one and done. Each month, it would behoove you to be able to make sure and go in and be up to date on that information, particularly if you know an individual would be likely to fall into that Medicaid eligibility status, or if you know that they have been seeking it. Also, a reminder, the Division of Behavioral Health is the payer of last resort and shall not pay for Medicaid-eligible services to Medicaid consumers. If you have questions about that, there's information in billing basics as well as contracts. So again, you can direct those questions to your region super users for help if you need specific information related to those expectations. So how is this going to work? what we're going to do is utilize files that are already being sent to the Heritage Health plans. This is an existing Medicaid file that has provider information. We also will be using a consumer eligibility file that includes both start and end dates of Medicaid eligibility. These two files will help to provide this functionality within the CDS. So again, there's two distinct files that will be used. The first is the consumer eligibility file, and this file will be sent on a daily basis, Monday through Saturday, and then on Sunday, if Sunday is the last calendar day of the month. The reason being, we also have a full replacement file that is sent on the last day of the month. For those daily Monday through Saturday files that are sent to the CDS, those will include any new or changed eligibility statuses. The provider file is sent every Saturday, and it includes all provider types for Medicaid and specialties, but really the distinct fields that we're looking at are those to be able to match the providers who are in the Medicaid network to those providers who are funded through the regions or the division directly. So these are the distinct fields that will be used for the Medicaid provider match. And so this is likely new to many of the folks on the phone, as it is to us at the division as well. But what Medicaid does is they have a distinct provider NPI detail number. That number consists of an NPI and then also a taxonomy. They also use a 9-digit zip or a zip +4. And so we have been working to be able to, from the current Medicaid file, be able to collect and to be able to fill as much of that information as possible. That being said, it does need to be double-checked and verified, and there are some situations in which we are unable to be able to distinguish what those fields will need to be, and so we may need more assistance from you to be able to plug those values in. Those are 3 new fields that will be in the EBS. So when you're working on contracts, again, things to be thinking about, things to be talking with anyone in your fiscal or billings office, because these are numbers that they will have access to through that Medicaid billing process. Again, these are not new numbers that we're creating. They are numbers that we are borrowing from in order to do the match and that already exist. Again, we recognize that you might not have kind of common knowledge of these, and so some of that will need to get worked through in those 3 weeks leading up to the September 1st time period in which billings will likely start. Again, on our side, we're using a match process looking at provider name and address, again, to help ensure that we're locating the appropriate taxonomy number and NPI. So shared services will be checked in a few different areas. They will be checked at admission. They will be checked upon seeking an authorization, so that might be pre-authorized, or it might come in the way of a continued stay review for authorization. We also have our continued care review checks that are done on a quarterly basis, and then of course on the monthly tabs. That being said, an encounter can be created for someone who is Medicaid eligible, because as that encounter is being created, the admission date has not yet been identified. And so it will let you create an encounter, but if you find out at any of these additional points that encounter actually is for someone who is Medicaid eligible, you can remove that encounter from the system so that way it's not hanging out there and it's as if it didn't actually exist. So this is a screenshot of what it would look like if you were submitting for authorization for community support and the individual was Medicaid eligible. You would get a reason for denial that looks like this. Medicaid criteria, the consumer is Medicaid eligible on June 30th, 2017. If you are not a provider who is part of the Medicaid network, you will not see this information, as you do not have the ability to access any Medicaid information for consumers. But for those of you who are in the Medicaid approved network, you will have access to this information, but again, it will only be relevant on those individuals who have Medicaid eligibility in those shared services that we already had presented. So when you go to the tabs, this is what it would look like if you were going to look at someone who was active in your enrollment. So there was an admission, they had not yet been discharged, or their discharge date had been within the same month, you would see that this individual, their authorization may have lapsed, so there may be no authorization in this month. But furthermore, if they're Medicaid eligible, you will have an alert as to this consumer is Medicaid eligible, no tags can be submitted, and there's no entry there. So this is just a reminder of some different expectations when it comes to retro payment. And I want to just kind of touch on this, and I want to open it up to, if Karen Harker has joined us as well, if she has anything further that she'd like to add. But again, this should be nothing new. The basis of this is that if, for reasons other than share of cost, which meaning you can't have a consumer who is paying down until Medicaid will pay, any sort of DBH or region funding, that is on the responsibility of the consumer, or if an individual is not found to have that service as medically necessary. For those two reasons, you cannot just have a DBH determination that you want to put them into DBH funding. Those are not allowed. That being said, if an individual has been denied for Medicaid for other reasons, there might be times in which that reimbursement can be made. So since that would be likely an unlikely situation, we know that we need to have some type of override process. And some of that, we have some, again, ideas and some concepts and some design that we have been working through with our vendor. But until this goes live, we are not likely to know or to be able to anticipate every occurrence in which that takes place. However, again, that would be the exception rather than the rule, and we would expect to see very few of those. And also, it is to be expected that there is a repayment within 60 days of the Medicaid denial, or that you would register, rather, a consumer into CDS within 60 days of that denial. Also, if there is a retroactive period and you find out that someone becomes Medicaid eligible, it is expected that those units be repaid to the region and the division for the period in which that eligibility for Medicaid now applies. So again, this is just a reminder of those expectations. Karen, is there anything that you would want to add?
No, in terms of these expectations that are on this board have been consistent in expectations for years, are not new. And then I have just ironically sent out some further clarification on how to bill for if there would be a situation that they would be in a prior fiscal year. I just sent out additional out to the regions, so that will be coming out to providers.
And one of the things that I just want to make note of is we know that this is a new process, as was the CDS when it got rolled out, as is the electronic billing system or the EBS with it getting rolled out. And so we have, with the regions, been working very collectively to make sure that we're trying to think through as many obstacles and challenges and being able to identify sort of that most user-friendly route of being able to even address issues, but also the systems have been built with that in mind. So you might be seeing different responses from different areas, but also please note that if you do have a question, you are welcome to address that to the EBS team or the CDS team or to your region super user or to the help desk. Again, we'll have our contact for help at the end, and we'll be able to route your question to the right place. We're all working off the same page and, again, working to find solutions as we have issues or as we have different bug fixes that are needed, et cetera. So again, the important thing is that really you're staying ahead of this and getting into the system to be able to give us that information so that we can work through and find a solution. So here are some questions that through part one of this training series were addressed or that have come up subsequently, or that even within our group we thought these are things that might be questions that come up across the providers or even within regions. So again, what agencies and locations are covered? Those are going to be the providers who are within that Medicaid approved network. And again, it's going to be by location. It's not collectively across an entire organization. For instance, if you have an organization and not every location is part of that Medicaid approved network, those locations will not be included in the Medicaid provider file. Those that are in the Medicaid approved and are part of that network will come across. So only those in that file are the ones who will be able to have access to this information and who will be seeing these alerts and also encountering any type of prevention from submitting TADs. The services that are covered are those authorized and registered services that we had on the slide. Again, those are the services in which both Medicaid and DBH and regions are currently paying for. This list at some point may grow. There may be additional services that Medicaid begins to fund, so this list is not concrete and forever, but rather it is about, again, ensuring the appropriate payer source for services that a payer source will cover is being used. Emergency services covered under this, again, going back to that list, we've got acute and subacute inpatient. However, things like EPC are not included in this connection. However, you might have an individual who comes in on an EPC and then very quickly goes into acute stay covered under Medicaid. So you will have some different things that in those emergency and crisis situations where things are moving very quickly that you'll want to try and do your best to, in a very timely manner, find out that information and understand the Medicaid eligibility to the very best of your ability. And again, this really is kind of that third layer of being able to have a checks and balance, because you might not always know even all of the information to be able to access some of that. But again, this is in complement to the NIMS, to the C1, to those other resources, and not a replacement for it. Is there an, the next question, if the CDS indicator of eligibility is an error, you believe, the first thing that you would need to do is to be able to work with Medicaid to be able to see what's going on that side. Again, all of this is being generated from their files. We have no direct influence or say or control over the information contained in those files, and so going to Medicaid, working with the Heritage Health Plans would be your first and direct line of contact if you feel like someone is not coming up or if you feel like someone is coming up in error. Is there an override process so that you can bill for unique situations? Again, we're looking into what is the best and most effective way to be able to have an override process and what that functionality looks like. Part of our issue is not having any sense right now of the volume of those in order to appropriately place that responsibility. So again, we'll be working with regions, being able to make that determination and coming up with a most appropriate and most effective solution. But there will be, and we are anticipating, the need for some overrides. So again, more information for that will be coming very quickly after this goes live. So we have some ideas and some designs sketched out, but once it goes live, we'll have a much better idea of what that appropriate and best solution will be for the override process. Does DBH pay during spend down? Again, the answer to that is no. The expectation is that if there's a certain amount of dollars that have to be spent before Medicaid will kick in, that is not funded through the region or division. This, again, is not a change. This is a current expectation. How many months back can the tags be changed? Currently, we have limitations to how far back we would expect you to go. That being said, there might need to be sort of this grace period as we find out. You might find out that someone's been on the tag for 7 months. So we're going to need to work through those scenarios as they come out. But on an expected basis, again, those time frames that go back to the billing and to the expectations there are the same as have been in place. Knowing that there could be eligibility for Medicaid that comes back even farther than 90 days. But technically speaking, we would expect that most of the months that would come into play would not exceed probably 3 months or 90 days back. Again, we might find that there are exceptions to that, but really looking at 3 months or less. And then the last question that we have posed, if after the TADS is completed and then the person becomes eligible for Medicaid, so you go back, you find out, oh, I actually had billed for August and September. Come October, I find out that they actually became eligible in July, and so I need to then be able to go back into the TADS, and I need to be able to zero those out, which will effectively send a zero status to the EBS and pay those units back. And I'm just going to repeat that again. If you find out that you have actually billed for a consumer who later becomes retro-eligible, so at the time of admission or authorization, there wasn't an eligibility for Medicaid in place, but you find that out after the fact, maybe a few months after the fact, it is the expectation that you go back to correct the TADS or work with your regions to correct those TADS. Again, we're going to figure out exactly that override process, but I just want to be clear, those will be paid back, as those units should then be paid through Medicaid, and those units would be reimbursed to the region and to the Division of Behavioral Health. So again, just a reminder of some important dates. So things that we have coming up as we are looking at next Monday, this is expected to be active with the Medicaid provider file and the Medicaid eligible consumer file to come into the CDS. So as you look at your TADS, you will see more red than even appeared on July 24th when we activated the authorization period. So for the next 3 weeks, again, you'll be wanting to get in and check those TADS sooner rather than later. Putting that off until the first week of September is not in your favor and likely will result in a delay in payments if there are issues. So again, I can't emphasize enough the need for you to be able to get in and know that you're in the clear, so to speak, for different consumers on your TADS. Next Thursday, just a reminder, once this goes live, please, if there are issues and questions, please send those. Report a data issue on those consumers, get that information into us. I wouldn't be surprised if there's sort of a flood of questions and issues that come up, but that will help prepare us for that Thursday call so that way we can be addressing those questions and again, thinking collectively with the regions on how to best address all of those and then working with our vendors and ISNT and Medicaid, again, to most effectively be able to come up with solutions to any issues that arise. So again, this is going to take some time to figure out. As the CDS came up new and had new processes and there's a learning curve there, the EBS is new, again, time to learn and figure out a whole new process, even though this has been a expectation, and even though this has been something in the past with Magellan that had taken place, and so it's not something that is new in concept, the way in which it's done is new, and so it'll take a little time to get it just right, and we're dependent upon your help to be able to do that. So checking eligibility now. Again, it is in your best interest to get in this week, and for those individuals who are on your TADS, double check that Medicaid eligibility. If you find out they are Medicaid eligible in one of those shared services, discharge them from the CDS now using the change in payer source for that discharge type, but also go through the process to be able to work on any sort of steps for the Medicaid to be able to get them enrolled in that plan, so that way you can have them in where they need to be with that appropriate funding source. The more you are able to get cleaned up before Monday, the less kind of heartache and work it will be later on, and likely less stress come billings in September. So again, this will ensure proper authorizations are in place with the appropriate payer source, and it will reduce complications with authorizations and billings moving forward. Next week, we want you to, again, after the go live of this Medicaid eligibility feed, get into the CDS and review the TADS immediately so that way, again, you can have a sense of who on your TADS for which services that red alert might be coming up that there are no TADs to be submitted. At that time, it is expected to identify if there's any thought that that is an error, if there are any issues, or if that individual needs to be discharged from the CDS and you need to follow the appropriate steps with the Medicaid plan to be able to get the individual switched over. Please also make sure that you are thinking about what those override needs might be. Again, we've got some thoughts on some exceptions. For instance, there might be a court who orders someone to treatment and they are Medicaid eligible, but they do not meet that Medicaid necessity. That is likely to be a very rare or the outlier type of situation. We might have someone who is mental health board committed who for one day might be DBH funded. So there are some rare exceptions. Again, these would be exceptions and unlikely to maybe come into play in your world, but again, we need to be thinking about that. So if you do see those, please let us know so that that way we can make sure that as we are creating the override function, we are taking those into consideration. Also, we'll need your assistance in making any corrections to the EBS provider information. Again, that's getting back to that provider NPI by that location with the 9-digit zip +4, and then also the taxonomy. We will also need to just make sure that you're attending the Q&A so that that way, as all of these questions come in following the feed becoming active, you can benefit from learning about what other providers might have experienced, because maybe you haven't experienced it in looking at your July or August TADs, but maybe it comes up in October. So again, that will be recorded as well, so it will be there as a resource, but hopefully folks can also make sure to attend the Q&A or have someone from your location or agency attend, and that'll be 10:30 to 11:30 next Thursday. All right, so if you'll give us just a minute, I'm going to go ahead and we're going to get logged into the test environment so we can do a little bit of a demonstration, as well as look to see if there are questions that have come into the chat box. All right, we do have a few questions that have come into the chat, and so I'm going to go ahead and read those, and then here as a group, we'll go ahead and kind of collectively respond to them as best we can if there's one that's come in that we're unable to address today. One of the other things is if we're able to by the time of the Q&A, we'll certainly address it then, or also we'll be putting out an FAQ with Medicaid so that that way we can make sure to include it there. But so the first question that we have is, for the retro period, will the CDS prohibit you from completing a TAD if the time frame is beyond the 60 days? The answer to that is no. The TADs will not prevent you to. The second part of the question is, if not, will EBS flag the transfer in some way?
The question will be, depending on when that transfer comes through, if it is on if that 60-day window falls on a prior fiscal year, yes, it will flag because it will not be able to electronically come in. There's another process, which, as I said earlier, is clarified in an email. Right now, there is not an electronic flag in EBS if it should come in at this time.
And one of the things that when we get into the demonstration, I will show just kind of some of the report options that we're looking at to be able to have means of being able to identify and address. And so that is going to be one of the ways in which we are able to kind of audit to or to be able to understand some of those things. So again, if you've got ideas, particularly regions for reports that you think would be helpful, please let us know. There's a comment about retro eligibility does not equate to an authorization, and that's accurate. That is absolutely true. So if someone becomes eligible for Medicaid in a retro eligibility way, that does not mean that they are automatically authorized for Medicaid. That being said, I think that there is some kind of grace period, but you will have to work with that Heritage Health Plan to be able to understand what those expectations are, what those steps are, and again, there are some services that don't require an authorization, and so there it would just be making sure that the individual is getting admitted into the appropriate plan, and that, again, if they had been on the tags and units had been submitted, that you would go back and be able to work through getting those units removed so that that way they could get zeroed out and submitted to EBS. The next question, how does paying back units to the region work since community support and day rehab are pre-authorized services for some Heritage Health plans? We cannot be paid for the months Medicaid was retroactive for a client since the service can be pre-auth before the person is actually Medicaid eligible.
The fact on whether or not Heritage Health, how or when Heritage Health pays you is irrelevant as to whether or not you owe DBH that money back.
And again, so be working with those plans to understand what those expectations are. And again, we're going to be putting out an FAQ in partnership with Medicaid so that way we can be addressing these questions to try and help, but there will be some things that are very specific to each of those plans. So again, just making sure that you're on top of what those expectations for authorization are so that way you have gone through the appropriate process in order to get paid. And just again to reiterate, again, the expectation is that if an individual is found out to be retro eligible, it is the expectation to go back and to repay those DBH region units. And again, this is why I would really, again, strongly encourage you, get in and find that out now. Go in and make those changes now. Go through the process of getting the authorization and working through that. The next question, retro eligibility does not equate to an authorization from the MCO. For instance, if we have billed for psych res rehab for June, then find out in August retro eligibility, we will not get an authorization from the MCO. If we have to credit our billing to the division, we will not get paid from anyone. Again, the expectation has always been that eligibility is being considered and that you have been following the appropriate authorization pathway for an individual and on top of knowing the eligibility. And again, I think that those questions to the MCOs would be beneficial for you to be asking, and I cannot speak for them, nor can anyone in this room, but again, we'll make sure that that question is addressed in our FAQ. Retro eligibility does not equate to an authorization. We've talked about that one. Will clients who become share of cost Medicaid eligible also be on the alert? If they are Medicaid eligible, they are Medicaid eligible. So they will be in the file and they will come across as someone who you should not be using division or region funds for. All right, so those are all of the questions really that we have now. Again, we'll be working to be able to, with Medicaid, talk about what those steps would be because, again, if there has been a retro period, what steps you'll need to go through in order to get that authorization. All right, we're going to hold for just a moment and bring up the test site. All right, so we're going to begin a little demonstration, and I'll walk through some of the things that you could expect to see beginning next Monday, August 14th, once this goes live. So you log into, and again, I'm in the test site. That's easily distinguished by the diagonal stripes here. Just a quick reminder, don't put actual consumer data in the test site, and don't put fake data in the real site. So again, make sure that you're using the appropriate site if you have access to the test site. So important to remember. But also, as I give that reminder, just a reminder that the information in this test environment is fake information, and so there is no PHI that will be being shared. All right, so what we're going to do is I'm going to sort of demonstrate somebody who has been enrolled and admitted into a service. And so I'm looking at my TADs, and we'll use an example. I'm going to actually use community support, mental health, and if my lists don't look like yours, it's because I have lots of permissions and access, but yours will be much easier to navigate than mine. However, we'll get there. So we'll use Community Support Region 3, Goodwill Industries of Nebraska as an example. We pull up our August TAD come next Monday when this feed is active, and we see we have an individual who has an alert come up. This consumer is Medicaid eligible. No TADs can be submitted for Miss Amy Abel. Again, fake individual. So I also see that there's actually no current authorization in this month for this individual, which would further prevent me from completing the TADs and submitting any units. Well, one of the things that why this individual is on the TAD is that they at some point had been admitted, community support being an authorized service. I can tell that this authorization has lapsed as there's no current authorization for them, but they had been admitted at some time. And so if I go back in time and I think back to Miss Amy Abel and when she first came in, and she came in May of 2016, and we actually submitted 1 month of community support, and we only had the 1 month authorized. So with that being said, when I would go to the next month for service, as of July 24th, what I would expect to see is no authorization for Ms. Abel in the next month because I only had 1 month of authorization. So again, fast forward to our current state of August 2007, again, now we have our Medicaid eligibility that is coming up because her eligibility has kicked in. So if we look back and we see on the earlier in the year, again, her Medicaid eligibility is there. So the expectation is, while her authorization was not current, but had I put in any units on her TADs prior to the authorization, prevention and the Medicaid eligibility prevention for submitting units, I would need to be working with my region to pay those back. So with that being said, I want to quickly go in, and I had mentioned a report. And so, again, we want thoughts and ideas, and we'll be working with the regions to be able to have different tools that we can access and use to be able to quickly identify any types of areas where this might be coming up, to be able to help work with you all to be able to get resolution. So this is the first report that has been developed, and again, we have other reports in development, but again, just sort of an idea of what type of report we're looking at. So here where we're running the report for Goodwill, we would see this is someone who is in that Medicaid file and is coming up as someone who is admitted into service, and so you can see that admit date and you can see the individual there. If we had additional people, they would also come up onto this list. So this list is intended to include all of those individuals who are currently enrolled in a program, meaning they have not been discharged in that month, and they are Medicaid eligible. and they need to be discharged, and those steps followed or those exceptions identified, but again, that's likely going to not be the case, so thinking about that discharge process. So we'll be working very closely with the regions to be able to come up with the best reports to equip you, the regions, and the division, both our data and fiscal teams as well as network, to be able to have some nice reports to be able to assist and to be able to make sure that those reimbursements have been made. So the next thing that I want to show you, kind of moving forward and being able to have a little bit of a step back. So if we're starting from more of a scratch basis, or say we have an individual who is currently in our, we're looking at our TADs and we want to be able to understand, we're going to choose here outpatient, and we're again going to do region 3, and we're going to say this is CHI. So we look at our tabs here. And let me open this up a little bit just for the ability to get in here and find something. So I'm CHI Richard Young Outpatient Clinic, and I'm going to be checking my tabs. So I've got medication management, and I've also got outpatient. So as part of this process, I need to be able to review my cases, look and make sure, again, following this becoming active on Monday, do I have anyone who I need to be aware of that I need to be thinking through, okay, I need to get this resolved and I need to get them switched over. So for July, the answer to that would be no. So now I'm going to do the same thing and I'm going to look and I'm going to say, okay, well, what about for August? So July, I'm in the clear. Now I want to do this for August, and again, this is all in preparation, making sure that what has just been billed, and you could go back as far as needed, but just for purposes of the demonstration, I'm just going to do the 2 months. So we look good for July, and then we look for August. So again, we're looking at this and being able to see, okay, has anybody come up here that we need to be aware of? And just for purposes of being able to more quickly view this, I'm going to go ahead and just select one service because it's difficult to scroll on the larger screen. And let me check here. Oh, I know what I'm doing. All right, so now I have Miss Lisa Engel, who has now in August come up that she is Medicaid eligible. So her start date can be assumed then to be August 1st because she didn't come up as Medicaid eligible in July. I was able to submit tags and units for her in July, but now come August, I need to discharge her and I need to go through and follow the appropriate process. So an easy way to do that, I'm going to click on her encounter. I'm going to go through and, all right, I know I need to discharge her from service. There are a few things I need to make sure that I've got. I'm going to need to have an address for her. I'm going to need to make sure that I've got an area for her. And forgive, I know this isn't likely the region where she is, but it's regions I'm most familiar with as far as city and zip. So for purposes here, we're going to go through and I'm just going to save. I'm going to go through, we've got diagnosis. I'm going to check and I'm going to make sure that all the information is as current and known as possible. And I'm going to go to discharge her. So the discharge date is July 31st. That's the last day that she was not Medicaid eligible. The last contact date that I actually had with her was the week prior to that. The discharge type, this is going to, again, be this change in funding. She is now Medicaid eligible. This is the result of why I am discharging her from this program in CDS, and I'm not discharging her entirely from the program, but I am discharging her from the CDS. So again, discharge referral. Well, this is really just to the self, so it's not that any referral has been made. You're still keeping her actually engaged in the service. You're simply changing the funding source. Destination, it remains the same treatment. And so we've got mental health outpatient. It remains that. I'm not certain about those, and so I go ahead and I process. Is she med compliant? Yes, she is, and so I'm going to process the discharge. So now I've discharged her. She's no longer going to be or should be expected to because of the time period in which her discharge date was. So then what I do as I go back to my TADS report and I refresh this, she's no longer on my August TADS. She's no longer an admitted consumer as of the last day of July. So that is the expectation as you're coming up with those. Again, it's going to be in your best interest to try and make sure if you've maybe neglected to be as timely as you should on checking the eligibility, or if you have people who have been in question, call today, call tomorrow to be able to find out on those folks and process them through. Again, it will just be easier without those things starting to get locked down. All right, I'm going to walk through one more example, and then we'll open it back up to see if there are any questions. And again, I just want for folks to be able to kind of see what it would look like in the system. And because of time and wanting to make sure that we have the ability to answer questions as well as capture questions to address next Thursday, I want to give time for that as well. But I'll do another example, and if there are more examples that you would like to see, please feel free to type those into the chat. And again, since this is new, I'm still learning, but to the best of my ability, I'll try and walk through what that scenario might look like. So I've got an individual, and I'm just going to pull one up that we've already got somebody, and I've begun the encounter for them, and they're working through, and this is, again, Amy. She's got some stuff that we're working on with her as a system, right? So this time it's behavioral health specialists in North Fork, and they are trying to get her admitted for short-term residential. And so as we go into this encounter, I had gone in and I put in some kind of base information for her, and I've got her diagnosis, and I've put in her alcohol use, and I've even submitted a questionnaire, completed a questionnaire for her based upon what I understand her treatment needs to be across the 6 dimensions, thinking about that ASAM, appropriate level of care. I feel really good about this in terms of the short-term residential need for SUD. I submit for authorization. Oh, she's Medicaid eligible. So I know at this point I need to then follow the process. I'm not going to be able to attain an authorization for Ms. Abel for my short-term res program through DVH region funding. Doesn't mean I'm not going to be able to get an authorization, but I now know I need to follow that eligibility, or I'm sorry, that authorization process for the Heritage Health plans. And again, this should be the exception. You should already be checking those other methods of being able to understand eligibility even prior to this point, but understanding that this is a daily feed that we're going to be getting. It might be more timely than you've had an opportunity in your office to check. So it's there to complement and to be able to help in that process. But again, so if you hadn't been able to have a chance to review that, and then you would follow those appropriate steps for authorization with her plan that she had selected. And then for this, I'm actually going to just remove this encounter. I get a removing an encounter request cannot be undone. If you wish to serve this consumer later, you'll be required to create a new encounter. Okay. Or, well, okay, she's Medicaid eligible, but she's telling me she's not. I might want to just hold on this for a moment to make sure. Now, with that being said, you don't want delinquents out there and you don't want it to last for too long. So again, you would be working with Medicaid to determine is she or is she not Medicaid eligible? Has there been some type of error? She finds out, oh, I didn't see that letter in the mail telling me that I was eligible. Yay, that's great, okay. So you go ahead and then you remove the encounter, and yes, you feel confident about removing it so that that way when you're doing your work, it's as if it hadn't been in there. So I'm going to conclude kind of with that in terms of a demonstration. Again, the different checkpoints for this will be at any sort of pre-authorization request, as I just walked through, at admission. Maybe they, at the time of pre-authorization, such as the case with Lisa, I was going through my pre-authorization and I was going through it on July 28th. She wasn't eligible right then, so there was no eligibility start date, but when I come to admit her on August 5th, she's coming in, and now it's hitting up against that, and I'm at that point of admission going to get a roadblock for being able to proceed with that admission because she's Medicaid eligible. And so again, this is a prompt. It's an alert to be able to bring you into that conversation, checking those other resources, and getting those records then cleaned up. The other point would be, if I had someone who had an authorization but then becomes Medicaid eligible, and I'm going in for a continued stay review, it's going to give you a check there, and it's going to give you that same denial reason because of Medicaid eligibility. On any continued care review, it's going to be checking up against it, and then lastly, but certainly not least, is on that monthly TADS, it will come up with that block saying that individual is Medicaid eligible. And again, the additional thing to look at is that authorization time period. If that's coming up and you have a continued stay review that's been in delay, you're not going to be able to submit TADS. So again, just to further reiterate, getting into your TADS and being able to look at that information is in your best interest prior to the week of billing. One of the other things that we've run into here lately are folks who are getting an authorization and not going through the steps of admitting them, and then come billing week, they thought that they had them in the system the whole time, they're not on the TADS, where are they? They were never admitted. So you need to make sure that even with those authorizations that are appropriate for DBH region funding, you're taking that additional step and getting them admitted. All right, so I'm going to go back to our screen here real quick to be able to look at and identify if there are any questions. So if you'll bear with me for just one moment here. All right, so I'm going to look in the chat window and see here if there's anything. All right, we've got some questions in here. The first one is, one Medicaid requirement is that clients must have an initial diagnostic interview in order for them to pay for services. This is not a DBH requirement. When retro authorization occurs and MCO will not pay, is this an exception that DBH will still pay for? So I know that the MCOs don't require our authorization process either. So one of the things that I think, just in terms of using good judgment and making sure, and part of the process to be able to ensure whichever authorization vehicle you need to be attaining, you might want to just make sure that all of those proper assessments and that Medicaid necessity is in place in order to be able to, if it's retro, go back and later attain the eligibility authorization that you would need. So again, there are different requirements. That point is very well taken, and we will work with MCOs and with Medicaid to try and make this as smooth as possible, knowing that there are some different things as far as criteria and expectations. But that being said, the second part of this question, when retro authorization occurs and the MCO will not pay, is it an exception that DBH will pay for? No. If they were Medicaid eligible, even in a retro sense, if they are Medicaid eligible and it is because of medical criteria or the share to cost, DBH will not be paying for those individuals, and it is the expectation those units will need to be paid back. The next statement here, this is a comment, and it says MCOs will, in fact, issue retro authorizations when a member receives retro eligibility. So again, thinking about that, and if you have someone who tends to be in that type of situation that tends to fall into Medicaid eligibility, and they might be one of your folks who swing back and forth on that, it would be in your best interest to be thoughtful and to be mindful about those expectations from the very beginning and making sure that you're working with that consumer, making sure that you're checking those Medicaid lines to check on that eligibility from the very beginning. Okay, the next question, how soon will this webinar recording and PowerPoint be available on the CDS? Would like to get it out to those not able to participate. We'll have to work through the recording, so hopefully everything with the sound and everything like that is good, but likely it will be out towards the beginning of next week. And again, a reminder, on Thursday we will hold another Q&A from 10:30 to 11:30 a.m. The PowerPoint will get loaded before the end of day tomorrow, but the recording will take a little bit longer. Will the report or does the eligibility message say the date eligibility began? The denial reason in the authorization does. For individuals who had previously been admitted on that on that report for the Medicaid exception, it also has when that admission date is, and that can be something that is taken into consideration to be able to add to that report, also to be able to think about the override and things like that about when that Medicaid eligibility begins. But also, this doesn't replace the NIMS and the C1, which will provide that information to you. Additionally, there's nothing like conversation with the consumer to be able to understand with them when their eligibility start dates began. You can also still work with the Medicaid program to be able to understand those dates. At this time, I don't see any further questions, but we will leave the chat box open for about 5 to 10 minutes until we don't see any more questions or requests for demonstration come in. And so with that, in case we don't receive any more, I do want to thank everybody so much for dialing in today and for your participation, as well as your patience and your help to be able to get this right and to be able to identify things that will need to get fixed before September 1st. So again, thank you everybody, and we'll be on hold here for just a few moments. As we're also kind of thinking about the last question a little bit more about the Medicaid eligibility date begin, one other thing for you to be able to use as a clue to that, similar to in my case with Amy Abel, is that if you start to go back months of the TADs, at which point that message is no longer there would be an indicator of when that Medicaid start date would be. So that first month in which you see that message would be the date of begin, and then any time in which then that message ceases would be the end date.